and progressing to 50% of ideal body weight. If we need to, we can go up to 60% of ideal body weight. So we'll give Tim the patient control, and after 3 to 5 minutes, and right now we'll assume that 3 to 5 minutes has gone by, we're going to take Tim into his barriers of right side bending and left rotation. So here we go. During the traction pull, we're going to take the table into right side bending until he feels a moderate stretch. We'll communicate with the patient, and then we're going to take him into left rotation. Now I move the bottom of the table to the right. Remember, left rotation is termed from the upper body moving on the lower body. So left rotation is actually moving the lower body to the right. So this is, by definition, left rotation, moving the lower body to the right. The upper body is actually moving to the left. I'm into Tim's barriers right now because he's distracted. This is a very comfortable stretch. Rarely do you have significant discomfort from this stretch. And because it's a prolonged stretch, it's very effective. Once the treatment has been completed, we're going to relock the table. We're going to return the table very, very closely, very, very slowly to the neutral position. And then before we get Tim up off the table, we're going to carefully loosen the belts, remove the harnesses, and we're going to ask Tim to very, very slowly move his knees back and forth. Traction treatments shut the back muscles down. They relax the back muscles. And we want those muscles to come back to life and help stabilize the back before we get Tim up. So for about a minute, we're just going to have Tim oscillate. And this technique, this movement is very, very important. So when people get up, their back is stabilized and they don't get that sharp pain. So let's just assume a minute has gone by and we will then get Tim up. Following this treatment, it's very, very important and helps with the effectiveness of the treatment to add in some specific stretching exercises people can do at home. The key points of module number 4. Number 1, do a thorough assessment and define the restricted movement patterns. With Tim, it was restricted right side bending and left rotation. Key point number 2, put the patient in traction in the most comfortable position for 3 to 5 minutes and then move into the barriers. Do a moderate stretch. No need to do a vigorous stretch. A moderate stretch with the patient distracted is very effective. Once the treatment is completed, the key point number 3, augment your stretching, your traction stretching program with a home exercise program that will help maintain that mobility. Remember, these are chronic conditions, and it will take some time, but you're going to improve each treatment and the symptoms will be reduced. The patient will feel this improvement. They'll be motivated to come back. They'll be motivated to follow through with your treatment recommendations. In module number 5, we're going to demonstrate how to treat lateral stenosis with peripheral symptoms from degenerative disc and degenerative joint disease. To treat this condition, we've put Tim in the most comfortable position possible. For these types of patients, that's usually in a supine position, on their back, knee supported with a bolster, neck nicely supported. And once we get them in that comfortable position, we'll program the 3D ActivTrac. We'll choose lumbar, intermittent. We'll use a short ramp time because this patient is not in acute pain. So ramp times of 30 seconds up and 30 seconds down. We'll choose a hold time of 1 minute, a rest time of 15 seconds. We'll maintain 25% force at rest. We'll choose a treatment time of 15 minutes and a treatment force, again, starting at 40% and progressing up to 50% and then up to 60% of ideal body weight. Once the program has been entered into the 3D ActivTrac, we give the patient control switch. We hit start and we're ready to go. We allow 3 to 5 minutes to elapse, and then we'll start to do our three-dimensional techniques to decompress the spinal nerve. Okay, 3 to 5 minutes of treatment time has gone by, and now the muscles are relaxed. The decompressive effect of distraction has occurred, and we're ready to start further decompression of this side of the spine. We're going to try to take some pressure off that nerve that's causing pain going down the right leg. First thing we're going to do, we're going to use the control switch here, and we're going to increase flexion. Increasing flexion will open up that foramen just a little bit. Okay, so first of all, we're going to distract. That decompresses. We're going to flex a little bit. Very slowly, a few degrees at a time. Okay, now we really have two dimensions of opening, don't we? We have distraction and we have flexion. All right, we're going to further decompress that nerve by side bending away from. Now we are distracted, we're flexed, and we have side bent away from the side of pain, and we're opening up that foramen. The last dimension that we're going to do to open that foramen up is we're going to rotate towards. I actually took the body, or the lower part of the body, away from, but that's actually a gapping technique. The upper body actually went towards the site of symptoms, and now we've opened that foramen up in 4 dimensions. I'm going to do this one more time. The first dimension is distraction, then flexion, side bending away, and gapping towards. That foramen is as open as it can possibly be. That lateral stenosis from the spurring and the arthritic condition in the posterior aspects of the spine that has been pushing on that nerve now is open. The pressure is off the nerve, and you'll start to see symptoms improve distally to proximally. In other words, the foot will get better, you'll start to see life come back in the leg, and then we're going to allow the treatment to finish. We'll have approximately 10 more minutes of treatment for that nerve to relax, reduce the inflammation, get some nourishment into the disc, hopefully maintain some of that opening when we're done with treatment. Once the treatment's done, after the full 15 minutes, we're not going to take the table back into the neutral posture. We're going to leave the patient in this posture. We're going to lower the table, and then we're going to instruct the patient, once we're done with the treatment, in ways to stay out of provocative positions. For most of these people, it would be extension and movements towards the site of symptoms. We want them to stay out of those postures while the inflammation is reduced in that sciatic nerve. The key points of module number 5. Number 1, we want to do a very detailed assessment to make sure that we identify not only the side of where the peripheral symptoms are for lateral stenosis, but the exact positions and motion that makes the problem better and makes the problem worse. We've identified that. Right-sided motions, we found that flexion, side bending away, rotation towards with the distraction relieved the pain in Tim's leg, which leads us to key point number 2. We want to wait 3 to 5 minutes before we open that table, or before we open that foramen and actually take Tim's body away from the site of symptoms. And the third key point is then to train Tim to stay away from those provocative positions. In other words, he needs to stay out of extension for a while. He can't side bend towards or rotate away from those from that side, which would put more pressure on that peripheral nerve. We want that nerve to settle down. We want the swelling to go down. The symptoms will diminish. Again, this is not a quick fix. They'll get a lot of relief of symptoms while on the table. Some of those symptoms will return once the traction treatment's done. But as that swelling goes down, as the inflammation goes down, then we'll see a gradual improvement in peripheral symptoms, improvement starting in the foot, and then improvement working up towards the hip. And the last thing to get better would be the lower back pain. In Module 6, we're going to demonstrate how to treat a nerve root adhesion. What you'll see here is basically the same setup that we finished with for the treatment of lateral stenosis. We have Tim flexed. He had the symptoms on the right. We have the table flexed. He was side bent away from those symptoms, and he was actually, upper body was rotated towards, and he was distracted. Now, nerve root adhesions are characterized by people that have some sciatic neuritis, some pain down the leg, but when they bend over to try to pick something up or tie their shoes, they get a dramatic increase in peripheral symptoms down the leg, and it's always at the same angle. With Tim, let's just say it's right here. He has dramatic increase of symptoms right here, and down here, maybe no symptoms at all, or a very light amount of symptoms. Lots of symptoms there, and there's a very firm end feel, and it's always in the same place at the same time. That nerve is stuck in the foramen. This can occur post-surgical, a number of months after surgery, but more commonly it's in a patient that has lateral stenosis or degenerative disc and degenerative joint disease and has had chronic back problems for many years. Eventually that nerve can scar down and get stuck in that foramen. And unfortunately for this patient, the only alternative other than what we're going to show you right now is a decompressive type of surgery. So this is a very, very important technique. So assuming that you've watched module number 5, we have opened that foramen up in 4 dimensions. Again, distraction, flexion, side bending away, and rotation towards. So that foramen is open. Now I'm going to show you a nerve gliding technique. It really works swell, but remember, you have to go very, very slow. We're not going to stretch the sciatic nerve. We are going to mobilize it. In other words, let me explain. If this was a sciatic nerve, we're not going to stretch it like this. We're going to move the neck and the leg together and move that sciatic nerve back and forth, just like you would dental floss. In fact, this technique is called flossing or nerve gliding. We're going to ask Tim to put the neck back. Okay. And this has to be done very carefully. We're going to take the leg and straight leg raise till we find the barrier and back off just a little bit. Okay, Tim, what I want you to do, can you raise your other leg just a little? There we go. And put it back down again. So I'm just off the barrier. The table is in the same setup as before. We have about 50% of ideal body weight. We do this technique while the table is applying traction so the spine is distracted. And Tim, I want you to slowly raise your head now. As he raises his head, I lower his leg. Slowly let your head back. Raise your head. Head back, a little slower. Raise. The entire spinal cord slides down, and it slides back. It slides down, it slides back. Okay? Now, typically we would do 3 sets of 5 movements. There's no magic number there. We want to be very careful that we're not doing a stretching technique. We're doing a gliding technique or a flossing technique. With the 4 dimensions of opening at the foramen, you're going to find that you're going to be able to generate some movement rather easily. And the tendency is to do too much too soon, so go very, very slow with this technique. We've had successes where everybody else and all the other conservative techniques have failed. With this extra opening, excellent chance of success. And Again, if we don't get this patient well, they're either going to have to live in chronic pain or they're going to have decompressive surgery. So this is just one of the great little tools that you can use to help this type of patient. The key points in Module 6 are similar to those in Module 5. Number 1, make sure you do a detailed assessment. You want to make sure that you're dealing with a nerve root adhesion here. You want to make sure that there's no sinister pathology, and so on. Establish a baseline. Remember those hard end fields that are always at the same range, and that will indicate a nerve root adhesion. Number 2, the same thing as before. You want to wait about 3 to 5 minutes, allow that spine to distract, allow the maximal opening of that foramen, and then start your mobilization or nerve glide. The third thing is, don't stretch. You don't want to be doing this. You want to be doing these motions. So carefully let the leg down as the patient raises the head up. Raise the leg up as the patient lets the head down. Kind of like a teeter-totter. You're moving that nerve in the foramen, but you're not significantly stretching the nerve. The last key point is to be patient and be careful and go very, very slow. The nerve is going to free up rather quickly, but just be careful. Don't bite off more than you can chew, because they might be quite inflamed the next day if you do too much. So get a feel, do several treatments before you get aggressive. In fact, you probably should never really be aggressive with this technique. It's taken a long time for this nerve to bind down, and just give it some time to loosen up. And just listen to your patient before you progress. It's a great technique. In module number 7, we're going to discuss how to treat a cervical spondylosis with peripheral symptoms in the arm. Let's just assume right now that Tim has neck pain and he has pain down his right arm. We've done a thorough assessment. We've eliminated sinister pathology. We have identified any contraindications. We now know that traction is just the ticket for this condition. And we've established a baseline of range of motion and of neurological signs and symptoms and so on. So if that's understood, what we're going to do next, we're going to have Tim sit up nice and straight here. And we notice that he has a little forward head carriage. Part of that is obviously related to his neck pain and arm pain. We're going to do a little assessment there, and we're going to match the table, the angle of the 3D ActivTrac headpiece and cervical piece to his neck posture. We're going to try to pull him in a neutral posture. Eventually we may extend the table a little bit as his neck condition improves, but right now I want to start him in the same position that he is in right now. So I'm going to ask Tim to put the middle of his neck between the rubber neck wedges. Kind of wiggle on in. I want to keep about a finger breadth between the occiput and the top of the rubber wedge. And I'm going to get a bolster that really helps relax the spine, the entire spine. People can clasp their hands, or sometimes they put their thumbs under their back so they can relax. Relaxation is very, very important here. And we have knobs on both sides, but we're going to comfortably tighten those rubber wedges against the side of the neck. If people are very flexible, they can actually do this themselves. In fact, many times people would rather do it themselves. Tim, I'm tightening these down. Can you reach back okay? Can you tighten those for me? I want those rubber wedges to be nice and snug. Not so snug that they're uncomfortable, but nice and snug. Many times, if we don't start the wedges in the middle of the neck, let's say we put them right up in the position up against the occiput and we start the treatment there, they're going to end up too high. If we start down in the middle of the neck where the neck is smaller, they'll come up into the proper position. Remember, these neck wedges move laterally, but they also rotate, and as they come up into position, they'll rotate, in most cases, into the proper position. The next thing we're going to do So we're going to put on the forehead strap, and I'm going to ask Tim to put your finger right there for me. That will allow me to have both my hands free to make sure I don't get hair caught in the straps, and I can protect the ears as I tighten this forehead strap snugly. My technique was to pull straight out very snugly. There should be no room. I wouldn't do this to a real patient, but Tim, try to raise your head. And I cannot get my fingers underneath his head at all. His head is firm against this little sponge plate. That head isn't going anyplace. If the head raises up, it's going to be uncomfortable, and the rubber wedges will get out of place on the back of the neck. We'll give him the patient control switch here, and we'll program in our protocol. Cervical, intermittent. He has acute pain, so I'm going to go 1 minute ramp up and 1 minute ramp down. I'm going to choose 1 minute hold and 15 seconds rest. It's important to know that there's no magic number here. Many people go 2 minutes on and 30 seconds off. That is also effective. I'm going to maintain a little bit of force at rest. The 3D ActivTrac works much better in the intermittent mode if you maintain a little bit of force, at 25% force at rest. We're going to go 15 minutes of treatment. Now let's talk about treatment force. The studies are pretty clear on this. It only takes about 10 or 15 pounds of force to distract the upper cervical area. So if you just have problems of headaches or muscular tension in the base, at the base of your skull and the upper neck, you may only need about 10 or 15 pounds. But for somebody like Tim, who has right arm pain and obvious problems down lower in the neck, you need much more. For a smaller adult individual, maybe a female, 25 pounds to distract the lower part of the neck. For a male, maybe, or a larger person, 35 pounds, up to 40 pounds to really distract all the way down into the lower part of the neck to get that decompressive effect. That doesn't mean you start out there, but that's where you're going to have to go to really get the distraction that you need. So for Tim, I'm going to start him out. Here's a big, tough athlete. Looking at his size, I'm actually going to start out at 25 pounds. I just have a feeling he'll tolerate that rather well. And remember, if it's too vigorous a pull, he'll tell me. I'm going to talk to him. I'm not going to just punch it in and walk away right away. I'm going to make sure he's comfortable before I go do some other activities. I can hit pause once I start the treatment and change time and force without wasting any of my time and without having to restart the treatment. So we're going to start at 25 pounds. We'll start the treatment. We'll stick around. And typically, somebody like this, many times you'll be able to go up to 25 or 30 pounds in the first treatment. Let's just say that I've found a treatment force of 30 pounds. We allow that magic number, those magic numbers, 3 to 5 minutes of time to pass. And our goal for treatment is to take the pressure off the nerves on the right side of the neck. So what we do, okay, now we're distracted with cervical traction. 3 to 5 minutes. We're going to side bend the table away. And then we're going to have Tim help us here just a little bit, but we're going to position him on the left side of the table. And now there's only a small angle, maybe 10 degrees or 12 degrees, but he is side bending to the left. That opens up the foramen on the right. And usually about that time, you'll start to see the symptoms in the right hand improve and the centralization of symptoms improving from distal to proximal. Once the treatment is done, what we're going to do, we're going to instruct him into staying out of those provocative positions. For somebody with neck symptoms like this would be side bending towards the symptoms, rotation towards the symptoms, extension, or any combination thereof. Once the treatment is complete, we'll get that patient control switch. We'll loosen the neck wedges. We'll carefully unfasten the forehead strap. We still have Tim positioned in that position that the neck is still decompressed.